Hello friends, this is a case of robotic cholecystectomy. Left hand we have a atraumatic grasper and right hand has a hook. So there was some request that many of the student has told that I should put some cholecystectomy video, because once they have learned the robotic surgery at our institute, after that they will start with the basic surgery. However, there is laparoscopy is very good for cholecystectomy. Robotic is not required, but during the learning curve you should start with the simple surgery. So I am demonstrating you this robotic cholecystectomy. We can see here that all the adhesions are getting separated. Generally in robotic we want to use the minimum number of the instrument to decrease the cost of the surgery. So here we are using only one hook and one atraumatic grasper. So left hand has a atraumatic grasper which is giving anteromedial and anterolateral traction over the gallbladder, and right hand has a hook which is doing the adhesiolysis. So slowly we can see here we are not using any fundus grasper, just left hand instrument itself is giving the retraction. We can see here that Rovier sulcus is visible and now all the adhesion is separated. After that we will give the anteromedial traction and then the posterior peritoneum will be separated. The steps of the surgery is just like cholecystectomy done by laparoscopy. There is no difference if you are doing laparoscopy or robotic. Only your tool is different, otherwise surgical steps are same. So we should always remain above the Rovier sulcus, and we can see slowly this is the anterolateral traction, and now this is anterolateral for the anterior peritoneum. And it is important that first we should all the visceral peritoneum we should separate, and that is called the skeletonization process. And we can see now the window, anterior window and posterior window is also formed, and the cystic duct is very nicely visible. However, here we will not use ICG. ICG can be used in also in the robotic, but here we will do without that. So almost we can see our separation of the cystic duct and cystic artery is complete, but cystic plate we will enlarge little more so that critical view of safety will be visible. So now clipping is also done same way. Here we will use hemolock, and this is one hemolock is applied, and the distance between first and second hemolock should be 3 mm and distance between the second and third hemolock should be 6 mm. So here whatever comes first you can apply. However, generally in the traditional way artery we should apply the hemolock first, but here we can see both the windows are nicely visible, CBD is down, and these two structures are clear cut entering into the gallbladder. So this is now the third hemolock is applied on the cystic duct, and we will cut in between the second and third. Now this is the artery behind, and the artery also hemolock will be applied. So this is the all the activity which is going on. You can see it is above the Rovier sulcus, and critical view of safety is nicely visible. However, if you want you can put the fourth port also, and you can ask your assistant with the 5 mm laparoscopic grasper to give the fundus traction, but here we are using only the 3 port. And now this is the scissors is cutting the cystic duct. This is laparoscopic scissors, this is not robotic scissors. So assistant is cutting, because we want to use minimum number of instrument which is applied, because you know the one use of the instrument will be costing you approximately 25 to 30,000 rupees. So only one atraumatic grasper in the left side, right side we have used hook and one hemolock. So only 3 robotic instruments are used, and all other instrument which is used is the scissors. Now this artery we will cut by the hook, and this hook is separating the artery above the hemolock, and after that carefully you can separate the anteromedial anterolateral traction, and first the peritoneum should be cut, after that automatically you will get a areolar tissue plane and you can easily separate the gallbladder from the liver. Because of 3 division, tremor filter and the motion scaling, these surgeries are very easy to perform by robotic, and hardly within 15 to 20 minutes you can perform the cholecystectomy. However, this was just a simple case, all gallbladders are not like that, and in difficult cases it takes a lot of time, but this was just a simple standard case of performing the robotic cholecystectomy. So, now the gallbladder is out, and to take it out from the abdomen we will put one laparoscopic claw forceps, and we will take it out by undocking one of the hook arm. We will undock, and after that we will introduce one claw forceps to take the gallbladder out. So, with the 8 mm also, if you will take the neck of the gallbladder out, you can cut it and you can suck the bile and it will be very easy to remove. However, sometime you can increase this 8 mm to 10 mm, and then the simple gallbladder extractor which is used in the laparoscopy is going to come and taking the gallbladder out. So, thank you very much for watching this video. This was just a simple case of robotic cholecystectomy.